Frank to Interlux for invitation. So we had before a very nice speeches regarding antimicrobial resistance, regarding antimicrobial stewardship, regarding sepsis. Me, I am representing an industry. I'm representing Becton Dickinson, and I'm working with this company since many years. And today I would like to show you what is the role of industry regarding what we can offer with surveillance of infections, so management of data. And in this, we will see what is the fundamental and critical role of the microbiology lab. Then, we have seen, as we said, regarding antimicrobial stewardship and how antimicrobial stewardship is instrumental to the reduction of antimicrobial resistance, what we call AMR. So the health care providers are have more and more challenges regarding reduction of cost, regarding management of infection, spread of infection. Then how can we answer to this? We can answer in different ways. We can answer with more integration of informatic systems in order to provide rapid answers. We can provide systems that deliver rapid results that can be used for taking the right decisions. Then we are just back from 3 years of pandemic. We have seen a lot of figures. Maybe we are not so much aware regarding antimicrobial resistance. Nevertheless, we have media that continuously reports new superbugs that are discovered and that pose a threat for the health of the patients. And we have different figures. So we have seen before what are the numbers regarding sepsis. What is the incidence of sepsis, the morbidity and mortality rate. These are public data. Maybe we are not so aware of that. We are not also so aware that it is fundamental in case of sepsis to make blood cultures, because in that way we are able to isolate the pathogen, and then we can better address the treatment. And this will reduce the use of wide spectrum antibiotics, and then reduce the incidence of antimicrobial resistance. We have also nice projections regarding the, I would say, antimicrobial resistance. So nice is an euphemism because numbers speaks by themselves. What is the incidence today of death due to antimicrobial resistance, and what are the projections for the future? There was a guy called Lord O'Neill, member of the Lord Chamber in the UK Parliament. And this made an interesting review on antimicrobial resistance and a projection for the year 2050. Just consider that Lord O'Neill is not a professor of medicine, he's not a microbiologist. He has experience as a consultant in Goldman & Sachs, so banking, finance, and as such, and as a conseiller of the of Cameroon's government in UK, has made a projection that if you don't intervene today, and intervening today means an investment of around $100 billion a year, in year 2050, we will have per year at least 10 million deaths due to antimicrobial resistance, and the cost to the community of $1 trillion. So a huge amount. Then it's important to cope with this today. And as we have seen before, is fundamental to have projects regarding antimicrobial stewardship. And antimicrobial stewardship, what does it mean? It means using antibiotics just when these are necessary, and not for infections other than bacterial or fungal infections. It is fundamental to use antimicrobials, which are target antimicrobials, and not wide-spectrum antimicrobials, and use it for the period which is necessary and just necessary for the treatment of infection. We have seen that here in Lithuania, you have committees, you have initiatives, you have projects for antimicrobial stewardships, and how these programs give their results in reducing not just the cost, but also in reducing the incidence of antimicrobial resistance. Because we do not want to be in the vicious cycle where we use antimicrobials indiscriminate, and then this means an increase of lymphostates for patients, increased mortality, increased morbidity, and increased cost. But we want to be in the cycles where, thanks to the results, to the diagnostic results coming to the lab, we can better address the antimicrobial treatment for the patient. And this helps in reducing antimicrobial resistance and helps in coping with nosocomial infections, because all these must be associated. Then, here we have the important role of the microbiology lab, because it is through the microbiology lab that we get the correct data, the correct result for treating the patient. If we don't request to the microbiology lab to do tests, if we do not provide the correct specimens, the correct material, the microbiology lab cannot help in this. Then, I wanted to speak a little bit now about some principles of epidemiological surveillance. So the microbiology lab is the central point, because by doing diagnostic, both on clinical samples and in surveillance samples, produces the valid information on which we can plan actions regarding control and prevention of infections. So here we have I would say, old but still valid definition of epidemiological surveillance, which is coming from CDC. What is a surveillance? Collection, so daily continuous collection of information, analysis, and interpretation of results, having the purpose of intervening immediately on single patients and planning actions, and then at the same time being able to see whether our project for containing the infections have proven to be effective or not, and then correct our plans, our actions. Then, what is the important role of the microbiology lab? The microbiology lab has to detect so-called alert sentinel organism. This is a pathogen-oriented surveillance. The microbiology lab is the first that raises the suspect of outbreaks. The microbiology lab has the information regarding new emerging pathogens. And I also say, but I forgot to put in this slide, indirect surveillance of infections. Then, you know very well what is the definition of a nosocomial infection. Then I do not want to linger on this one. But nevertheless, each institution should have a correct definitions regarding timing from admission of patient and collection of samples to define whether it is or not a nosocomial infections. Same happens in case of discharge of patients. So what are the criteria for inclusion or not? Then, definition of sentinel organism, of alert organism. You can find these in all publications of CDC, and each institution has its own list of alert organisms that can differ for some organisms, for some infections, but substantially is the same for everybody. So these are organisms that are easily transmittable, that are permanent, that are resistant to more classes or antimicrobial, that therefore is not easy to treat infections caused by these organisms. Then, what is the role of surveillance? Prevent spreading and transmission of infections from a patient to patient, patient to staff and staff, so personnel to patient. Prevent outbreaks. Then control the circulation of phenotypes and communicate to health authorities, communicate to surveillance in case we have indication of environmental contamination, of lack of hygiene. Role of the lab in case of alert organism detection. So real-time detection of alert organism. So we have today, and this will be part of my speech later, automatic systems that are able to raise alerts for that. Then communication, not just through chat report, LIS reports, but using also real-time communication system by reaching the professionals that have to take care of the patient for isolation measures, court, and so on. Then, monitoring circulation of resistant bugs. Then, this is an example, these are examples of indirect surveillance of infection, which is done through the microbiology lab. So these are examples taken from CDC. We have a central catheter associated infection, urinary tract infection associated to catheter, surgical site infections, mechanical ventilation associated infection, tuberculosis. So the most common infections that are controlled. But the institutions and the Committee for Infection Control should have predefined protocols. And all the stakeholders should apply the same protocols regarding the criteria for inclusion, regarding testing, microbiological testing of samples in order to collect information. Then, what are the indicators that we should use? So, attack ratio, risk indicators, then correct definition of the delay time to use between admission date and time and collection date and time to include or exclude. So, to consider as a nosocomial infection, what we call today healthcare-associated infections or community-acquired infections. Then the lab plays a fundamental role because it is the first to get the suspicion of outbreaks, and these contributes together with the wards and together with the nurses for infection control. Then the lab should identify, should the first raise the alert when by looking at the data for the previous days, previous weeks, we see an increase in the percent of isolation of resistant bugs. Then he has to identify the etiological agents, so the pathogen which is responsible for the outbreak. try to define what is the reservoir, whether we have a unique reservoir or multiple reservoirs. The way of transmissions. The way of transmission through the patient, the personnel, considering that today we have a patient and also personnel moving between different wards of the same institution or between different institutions. Then the purpose is that to eliminate the reservoir and make the controls so that the outbreaks does not repeat any longer. And in this, so this is a long flow chart that I don't want to go into details. The lab has nowadays all the means to do that. Can do phenotyping, can do genotyping in order to recognize whether there is a chain of transmission between patients, between staff of the Sentinel box. Then, the fundamental role of the microbiology lab. To have protocols for detection of AMR. System, equipment, not just instrument, but also software that help to detect in real time and efficiently the organism involved in outbreaks and in nosocomial infections. Then the lab should use criteria, as we said, to differentiate also between surveillance samples and diagnostic samples. And these should be included in the protocols that I use. So Becton Dickinson is one of these companies that can provide all the material and equipment for the lab, from collection to production of reports and analysis of data. I do not go so much into details. Consider that we have systems for blood culturing, for collection, for blood culturing, automatic systems. We have a system, not just culture media, but also automatic system that permit inoculation of samples to plate, automatic incubation, taking the image of cultures to identify the pathogens, algorithms that permit to differentiate between positive and negative cultures, and also identify, presumably on the plate, directly the pathogens. We have a system for rapid identification, like MALDI, and system that provides antibiogram. Antibiogram both as MIC and as disease diffusion. Then we also have systems for management of data, and which produce reports and alerts which are used for surveillance of infections. So today I will speak about our consolidated system, which is Epicenter. We are developing another system, which is on a web format, whose access is available to all personnel and workers in an institution, not just for the lab. Then, so as a company, we have the advantage to produce both instrument for the lab and informatic system. So we can link all these instruments to our informatic platforms so that we can generate a consistent database of information that we can then exploit for epidemiology and for surveillance. In fact, we have platforms for epidemiology and platforms for surveillance. I do not focus today so much on the platform for epidemiology, which is very useful, for example, for establishing what are the protocols for empirical treatment of infections. I will focus on epidemiological surveillance, where the purpose is that of capturing single events. So we are not interested to percent to final scores. We have to detect the single patient that are affected by sentinel organism, by organism that show unexpected resistance to antimicrobials. These can be done real time, can be done through alerts that the system can issue based on rules that we can create in the system. Then, the purpose is exactly that of discovering cases of nosocomial infections, so healthcare-acquired infections, suspicion as a suspicion, and then as a confirmation. To identify outbreaks, to identify the source of infection, to evaluate which is the way of transmission of bugs responsible of nosocomial infections, and to report to health authorities and surveillance authorities. Then, this is the pathway which is used and which we follow with the platforms that we have for surveillance of infection. So we perform a search on a population or subpopulation, which is the object of surveillance. We have to identify outbreaks. We have to identify patient index. And then whether there is a connection between a patient having the same isolate as ID profile and as antimicrobial susceptibility profile. We have to detect the origin, the source, and then what is the number of patients that are affected. Establish whether this is healthcare associated, and then communicate to health authorities. So this is a rapid demonstration of some examples. We can evaluate what is the efficiency and efficacy of the different diagnostic methods used by the lab in detecting antimicrobial resistance, in detecting the bugs in the culture, and also comparing other methods like molecular biology. We can make a surveillance regarding samples. So how many samples produce isolates? And this gives an idea of what is the efficiency of our methods, not just, but also of the adequacy of the request of the clinicians for diagnostic testing. We have a surveillance based on single patient. So we have patients that are more fragile and are for which we have to make a special monitoring of all the isolate that we can get. Then we can extend these to an hospital service for a period of time to see what are the sample positives and the bugs, the organism that we have isolated. Then, to identify outbreaks. So this should be a daily review of the isolate of the day and comparing the isolate of different samples. So the system automatically is able to identify the samples, not just in a ward, but in an institution, having similar, equivalent phenotypes. Then it's up to the lab to proceed eventually to further testing with sequencing to identify whether it's exactly the same phenotype circulating. So we have a different type of tables, graphs, reports that are used for that. Then, when we have identified the phenotypes for which we want to make surveillance, we can have descriptive surveillance in the sense that we can set rules so that the system alerts us in case these phenotypes that have a defined resistant mechanism, defined resistant antimicrobials or susceptible antimicrobial circulate and are found in a different patient. Then, we have automatic rules that set a suspicion and or confirmation of healthcare-associated infections. We have reports, different type of reports for reporting the patient affected by sentinel organism, by infections that for reporting to health authorities and surveillance authorities. Then, regarding real-time detection, we have systems that automatically alert the microbiologist, the lab, but also clinicians and infection control when we have a discovery of a sentinel organism in a patient, when we have a suspicion of nosocomial infections. This is for activating measures for isolation, courting eventually. When we have confirmation of nosocomial infections, not to consider cases where we have suspect of environmental contamination or poor hygiene. A clinician can be alerted when the system for blood culturings detects a viral positive to take measures when the patient is not yet under empirical treatment, or any culture is positive, or microscopy providing some results, and antibiogram providing resistant mechanism. So this could be done through Epicenter that alerts with pop-ups, messages, and acoustic alerts, or it can be done through email that pops up on computers or on cell phones, alerting just specific personnel and not all the world for conditions that need immediate actions. And these conditions can be established through rules in the system that the user can generate. Then we said, to conclude, that we also have a module for epidemiology, which is used for statistics. But this is different from surveillance, because surveillance is for immediate intervention. This gives the pace of the rate of nosocomial infections, of sentinel organism, and the circulation. Then, we have seen the fundamental role of the microbiology lab. Microbiology lab, which is the first one to issue the suspicion of nosocomial infection. Today, informatic, so IT systems are fundamental for surveillance, for epidemiology. They use expert systems. They use banks for sequencing profiles. So, without these, I don't know how it would be possible to have an effective surveillance. Then, we have automatic detection alerts. Nevertheless, review of historical data is always necessary to establish what is the trending of infection. The lab is fundamental, then, for detection of sentinel organism and for detection of outbreaks. Thank you so much. I'm available for